How do you recognize and manage immune-mediated hepatotoxicity? Immune-mediated hepatotoxicity is generally asymptomatic, and it's something that you'll pick up on routine liver function tests that you should obtain prior to every single dose of an immune checkpoint inhibitor. If there are symptoms, you could see things such as abdominal pain or bloating, dyspepsia, jaundice, or nausea, but it's rare that patients have symptoms from a mild hepatitis, and again, it's usually picked up on routine blood tests. The typical time to onset is about 8 to 12 weeks in single agent and sooner in combination. If a patient does have elevated liver function tests, there are a couple things to think about, as there may be other causes that are unrelated to the immune checkpoint inhibitor. First, review the medications, looking for medications that are hepatotoxic, particularly acetaminophen use. Review the alcohol history, obtain a hepatitis panel to rule out infectious causes, and consider the possibility of gallstones or liver metastasis, and you may want to obtain a CT or ultrasound to rule those things out. If patients do have elevated liver function tests, such as an AST or an ALT greater than 3 times or less than 3 times the upper limit of normal, or a bilirubin of 1.5 times the upper limit of normal, you can continue the immunotherapy, but it's important to check the liver function tests at least 1 to 2 times weekly to make sure that they aren't rising and that they're improving. Obviously, we're going to discontinue all of the hepatotoxic medications that a patient is on and monitor them closely. If patients have grade 2 elevations in their liver function tests, you can hold the immune checkpoint inhibitor and resume when the liver function tests resolve to a grade 1 or less, or if they're on prednisone less than 10 milligrams per day. If patients have severe toxicity, it's important to discontinue the immune checkpoint inhibitors and start methylprednisone 1 to 2 milligrams per kilogram per day. Monitor LFTs daily. If the LFTs do not improve, there are other agents that can be used, such as mycophenolate mofetil, but it's not recommended to use infliximab in this setting, as there is a theoretical risk of liver toxicity. A steroid taper can be attempted approximately 4 to 6 weeks if symptoms have resolved and the liver function tests have improved to grade 1 or less.